We're going to shift our focus to breast cancer now. We will first start with early breast cancer and then a presentation on metastatic breast cancer. In the breast cancer world, our next two speakers really require no introduction because they're speaking at every conference that I attend, which is wonderful. So Dr. Kevin Kalinsky is going to start us off with early breast cancer. Dr. Kalinsky is director, Glenn Family Breast Cancer Center, Winship Cancer Institute of Emory University. Welcome.
Thank you. Hi, everybody. It's good to see you. It was mentioned we're going to be shifting the focus and talking about early stage breast cancer. I will just say, I lived in New York City for 13 years and I moved down to Atlanta for the last 2. And I came here. I don't know what is going on with the weather, but I do know that the South has definitely had an impact on me because now I'm very frail and can't tolerate this. These are my disclosures. And similar to what was just mentioned in the last talk, there's lots that we can talk about for early stage breast cancer, but I decided to really narrow it down and talk about patients with hormone receptor positive HER2 negative disease and highlight some of the controversies, and then I'm happy to answer any questions that may come up for this subtype of breast cancer. If we want to talk about triple negative and HER2 positive, happy to talk about that as well. But as I said, I'm going to talk about hormone receptor positive HER2 negative breast cancer, and we're going to spend a good amount of time just talking about genomic assays. And with any development of a biomarker, it goes through various stages. Is there analytic validity? And this also has some tie-in to what we were just discussing with ctDNA. Is the assay reliable and is it reproducible? Is there clinical validity? Is there an association with clinical outcome? And then clinical utility, meaning, and this is really the holy grail of utilization of a biomarker, does the treatment change based upon what is seen in that specific assay? So I want to just mention the TAILORx trial. This is a landmark study. We were familiar with this study for patients hormone receptor positive, HER2 negative breast cancer, one of the largest studies that was conducted within the NCI. These data were presented at ASCO a couple years ago, published in the New England Journal of Medicine at San Antonio, which will be happening in the next couple of weeks. We will see the 12-year follow-up data from TAILORx. But what I'll be presenting now is the 9-year follow-up. So the way that this study was designed is if patients had a recurrence score that was less than 11, utilizing the 21-gene Oncotype DX recurrence score, patients received endocrine therapy alone. If the recurrence score was greater than 25, patients received chemotherapy followed by endocrine therapy, and then they were followed as part of TAILORx. But really the question of this study was for that intermediate group. If your recurrence score was between 11 and 25, what is the benefit of chemotherapy? And that's where those patients were randomized. And as I mentioned, for the 9-year event-free, the event rates at 9 years, we saw that this assay is prognostic, and that's really highlighted in the fact that patients who have recurrence score that's less than 11, that they do quite well if they receive endocrine therapy alone. And if their recurrence score is greater than 25, despite receiving chemotherapy, they still had a recurrence score, a distant recurrence risk of 13%. And then if you look at the overall population, those who had a recurrence score between 11 to 25, overall, there's no difference between any of the outcomes, IDFS, distant relapse-free interval, survival, and relapse-free interval. But in an exploratory subgroup analysis, when they looked at age, they saw that there was a statistically significant chemotherapy treatment interaction, meaning that the potential benefit of chemotherapy, when you look at those curves, differed if a patient was greater than 50 or less than or equal to 50, with age potentially serving as a surrogate for menopausal status. So there were data that then subsequently came out, were also published in the New England Journal of Medicine, and there's one thing that I really want to hit and stress is that it's not just the score by itself. It is also clinical and pathologic features that help inform the patient's risk and whether there could potentially be a benefit for chemotherapy. And that's really highlighted in this table. As I mentioned, there were the patients who were 50 years of age or younger. There were some in that cohort that seemed to benefit from the addition of chemotherapy. Those who had recurrence scores 16 to 20 or 21 to 25. But if you dig a little deeper in an exploratory analysis, the study was certainly not powered to look at these specific subgroups, But for those patients who had recurrence score 16 to 20, if they were low clinical risk, as defined as at the bottom of the table, these were patients who didn't seem to benefit from the addition of chemotherapy. Though if you were higher clinical risk, there was an absolute benefit of about 6.5%, and you can see, it's a small cohort of patients, and then there's a wide standard error. For those patients who had a recurrence score 21 to 25, regardless of clinical risk, again, for these patients who were less than or equal to 50 years of age, there was a numeric benefit for receiving chemotherapy. So I mentioned that higher risk population, those who had recurrence score that was greater than 25, and these are data that were subsequently published in JAMA Oncology, where you can see what would have been expected if patients had received endocrine therapy alone, as demonstrated by the white bar, and then those who were actually on the trial and received chemotherapy followed by endocrine therapy. And you can see that for both the group of recurrence score 26 to 30, or those who are greater than 30 in terms of their recurrence score, you did better than what was expected with endocrine therapy alone. So again, I just want to highlight this point that it is the incorporation also of clinical and pathologic features that help discriminate what one's risk is. And this is something that I utilize in clinic on a nearly weekly basis for patients with hormone receptor positive, HER2 negative breast cancer with lymph node negative disease. And this is a calculation tool, RSClin, which is available online on the Genomic Health or Exact Sciences website, where you put in the score, you put in different features like tumor size, grade, the type of hormonal therapy, their age at surgery, and you can see what their individualized distant recurrence risk is at 10 years. And it also gives you an individualized absolute chemotherapy benefit. So when you send the test off and you get that report back, I highly encourage you to also put in these various features, because you can see that that risk will either go down or up depending upon some of these additional clinical and pathologic features. It is important to note that this only applies for patients with no negative disease. In TAILORx, when you look at some of the subgroups, when you look at very young women, that is underrepresented. And when they validated this for prognosis and prediction, again in the node-negative population, they were only able to validate this for prognosis. So I want to move on and just talk about patients with node-positive disease. So we saw the results of Responder. These were presented about 2 years ago at San Antonio and then published in the New England Journal of Medicine last year. Also say at San Antonio, upcoming in the next couple of weeks, we have lots of data with Responder, patient-reported outcomes, race, ethnicity data, and then also the information regarding HER2 low status. So more to come within this study. But let's review a little bit about the study. So patients, hormone receptor positive, HER2 negative with 1 to 3 nodes involved. And different than TAILORx, if patients had a recurrence score that was greater than 25, they were off study, recommended to receive chemotherapy followed by endocrine therapy, but we did not follow them as part of the Responder study. If your recurrence score was 0 to 25, we randomized about 5,000 patients to chemotherapy followed by endocrine therapy versus endocrine therapy alone. And the take-home from this analysis, when you look at invasive disease-free survival, which was the primary endpoint, you can see in the postmenopausal group no difference if you had a recurrence score of 0 to 25 with the addition of chemotherapy. It was which was about 2/3 of the population. For those patients who were premenopausal, we saw that there was a benefit of chemotherapy, where we could see at 5 years an IDFS benefit of about 5%. So these are some data that were included in the supplement. I just wanted to highlight that if you look at the definition of premenopausal women, or if you look at the definition of based upon age, you can see across the continuum of recurrence score that there are still patients who have recurrence scores 0 to 10 who are still benefiting from the addition of chemotherapy. And you can see that the curves look about the same, though if you look at age 50 or less, that it's a little bit more linear once you get to recurrence scores 16 to 20 compared to what you see for those who, based upon just the definition of premenopausal women. So there are limitations to this study. We're still awaiting about 1/3 of patients to experience events. I think one of the major controversies from this study is, what's really driving the benefit that we see for premenopausal women? Is it the fact that we see cessation of their menses, or is there a difference in the biology that we see in a premenopausal patient compared to a postmenopausal patient? I.e., is this an indirect effect or a direct effect? It's also worth highlighting that few women underwent ovarian function suppression, which one would argue in this population is optimal endocrine therapy. Only about 16% of patients underwent ovarian function suppression. And there's some generalizability issues, meaning the majority of patients had one node involved, only about 10% of patients had 3 nodes involved. Very few patients had 5 centimeter or greater tumors, and only about 5% of patients were non-Hispanic Black. And I already mentioned that we'll be reporting at San Antonio during the oral session the difference between non-Hispanic Black and non-Hispanic White, which I think will generate some discussion. So to address what I had mentioned in terms of that premenopausal population, I just want to highlight that there is a study that should hopefully be opening within the next year or so. Again, all premenopausal, hormone receptor positive, HER2 negative breast cancer for patients who are node negative and have that high clinical risk recurrence score 16 to 20, or have a recurrence score of 21 to 25, or anybody who would have been in that responder population of recurrence score 0 to 25 with 1 to 3 nodes involved, will be randomized to ovarian function suppression plus an AI with or without chemotherapy. And so this study, which will be about 4,000 patients, will specifically address the question in a genomically defined population, can patients just do ovarian function suppression and hormonal therapy, and do they really need cytotoxic systemic therapy? I would be remiss by not mentioning that there are other assays that are available, and we'll spend a little bit of time just talking about the 70-gene Mammaprint assay. I also want to mention that there are other assays like Breast Cancer Index, which is available, and its clinical utility is really in the question of what's a patient's risk from years 5 to 10, and is there a potential benefit from extending endocrine therapy beyond 5 years. So I mentioned the 70-gene assay, and this was evaluated in the MINDAC study, which was also published in the New England Journal of Medicine, which was asking a different question. So this was looking if you have a discordance between your clinical risk and your genomic risk, how do patients do? And we saw with the primary endpoint where you look at that high clinical risk, low genomic risk population, that there was really no benefit from chemotherapy. And there are individuals within our institution that still utilize the Mammaprint assay, and the comment that I made about the Oncotype DX score still applies here. When one utilizes a Mammaprint assay, I think it is important to think about it in the context of, well, what was the clinical risk, right? If you have a low genomic risk, was this patient clinical risk high or clinical risk low? So I just want to make that caveat. So they did, in an exploratory way, look at those patients who were clinical high, genomic low risk, looking whether they received chemotherapy or not, and looking at distant metastasis-free survival. This was an updated analysis at 8 years, where we saw overall that there was no benefit with the addition of chemotherapy. But again, similar to what we had seen for TAILORx as well as Responder, when you look at those patients who are age 50 or less, these were the patients for whom there was about a 5% benefit in distant metastasis-free survival at 8 years. The patients who are age greater than 50, no benefit from chemotherapy. It is important to highlight that not all the genomic assays are the same. We've seen from the Trans-ATAC study, which was the biomarker sub-study of the larger ATAC study, which compared different endocrine therapies in the adjuvant setting. We've learned a lot from these particular studies, and what you can see here is if you look at years 5 to 10, and you look at how do these different assays perform as prognostic signatures, you can see in both the node negative and the node positive population that there's some differences in terms of how prognostic they can be and what their C index can be. So lastly, before we take any sort of questions, I do also just want to highlight, because we're talking about hormone receptor positive, HER2 negative disease in the adjuvant setting, Monarch E. We will see updated data at San Antonio, I think with 4-year data from Monarch E. This was also a practice-changing study which led to the approval of abemaciclib, the CDK4/6 inhibitor, in the adjuvant setting. So the way that this study was designed is there were two cohorts. There was cohort 1, which was high risk based on clinical and pathologic features, meaning patients who had 4 or more axillary lymph nodes involved, or 1 to 3 nodes involved, and having a T3 or greater tumor or grade 3 disease. And then there was a cohort 2, which the inclusion was just high risk based on Ki-67. So in this particular study, about little greater than 5,500 patients were randomized in a 1-to-1 fashion to endocrine therapy with or without abemaciclib. And again, the abemaciclib was taken twice a day for a total of 2 years, and the primary endpoint being invasive disease-free survival. And just to highlight the take-home point, one, if we look at Ki-67, which has been a marker which has had multiple controversy over the last several decades, you can see that it is prognostic, meaning if you have higher Ki-67, your risk is greater, but it was not predictive. So when we look at these data, we see that the benefit, absolute benefit, seems to be greater for those who have a higher Ki-67. But again, the relative risk is the same regardless, the relative benefit is the same regardless of Ki-67. So this did lead to the approval of abemaciclib in patients with early stage breast cancer. When we look at the FDA approval, it is based on Ki-67. And for those patients, for instance, who have 1 to 3 nodes involved, the FDA label includes having a tumor that's 5 centimeters or greater or a grade 3 tumor. ASCO did come up with some rapid recommendations, and these were a little bit more lenient than what was in the label, making the potential utilization of abemaciclib a little bit broader than the stricter label by the FDA. And then lastly, similar to the last talk that was given for patients with colorectal cancer, there's a lot of interest in circulating markers for patients with hormone receptor positive, HER2 negative disease. There have been some prospective, retrospective studies with circulating tumor DNA and CTCs. I'm showing you some data from a prospective, retrospective study looking at the ER-positive cohort. As was already mentioned, there are different ctDNA platforms. Those are bespoke assays versus those that are agnostic. I think in breast cancer, we're a little bit further behind than our colorectal colleagues, though there are some studies that are hopefully soon to open through the NCI looking at the potential role of circulating tumor DNA and switching therapy. Because I think really the question that we have in breast cancer is, we know that this can be potentially prognostic. However, in breast cancer, we don't know if you have positive ctDNA. Well, what's the rate of having asymptomatic systemic metastasis? And also, we don't know whether it's predictive, meaning if you switch the therapy, is it decreasing the likelihood of recurrence? And also, if you're switching therapy, can you have clearance of ctDNA? So I think in breast cancer, we're a little bit further behind, and there's still a number of questions that we need to ask in prospective studies. So in conclusion, hopefully I've conveyed that we've made some progress in chemo de-escalation based upon TAILORx and Responder and MINDACT. In premenopausal patients, we still need to identify some de-escalation strategies to prevent recurrence. We talked about abemaciclib in patients with high-risk early-stage breast cancer. Late recurrence remains a significant issue with this disease, and hopefully there'll be some potential interventions, including the incorporation of circulating markers, and this remains a critical unmet need. Thank you for your attention. I look forward to any questions that you may have.
Thank you. Do we have questions? Do you have a patient population that you use breast cancer index testing in?
Yeah, so the data with breast cancer index, which again is looking at different genes, is looking at H over I. When it's really been validated in patients with node negative or 1 to 3 nodes involved, there are really no data for patients with N2 or greater disease. I don't utilize it in all my patients. The data have been really from prospective, retrospective studies. Most of the data have been consistent. There have been some studies, including from the NSVP, where didn't show that same sort of prognostic and predictive utility, but that study was a bit unique in that the majority of events were local regional events and not distant events. So when I utilize this assay, it's really for patients who have tolerated their endocrine therapy, because I'm sure that others in this audience have patients that are counting down the days, like every single day till they hit their 5 years and then they're done. And then there's some patients who are doing quite well. And I do think it could be helpful for there to be an objective measure. And also, I don't really check this test for those patients for whom I'm considering till we're maybe about 4.5 years in, because again, not everybody's able to be adherent to the endocrine therapy.
Do you use it in your lymph node negative early stage as well, or do you reserve it more for the lymph node positive women that maybe have more risk?
Yeah, I do tend to, for patients that I have utilized it in both populations. I will say for my patients who have T1 disease that's node negative, I'm a little less, that's a population I don't so much utilize it in.
Any other questions? Well, I'm having more patients asking me about MRD assays like Signatera. What do you say to them when they're early stage?
We also, I would say I get this question probably once a week.
Right.
And I do think for patients with breast cancer, the only prospective data that we really have is from Nick Turner's data, the CTRAC study, in patients where they were looking to see about the potential utilization of pembrolizumab. And in that study, patients really did badly. There are some questions about that study in terms of whether patients were getting regular imaging, things like that. So we really don't have any results from prospective studies, and I don't think we're quite ready for prime time. There are some ongoing studies, like for instance at our institution we have a study called the DARE study, which is a national study being run by our colleague Lajos Putsai at Yale for patients who've been on endocrine therapy for 6 months to up to 7 years, where we're checking the Natera assay, and then if it's positive, then we're doing scans, making sure they don't have radiographic progression, and then they're randomized to continue on that therapy versus switching to Faslodex plus Palbo. But I do think we need results of those kinds of studies really to know what its potential clinical utility is.
They're so hopeful when they ask, and it's hard to sort of explain
For
why
sure.
we might not pursue that.
For sure. And I think the other thing that we're seeing in these studies is that for ER positive, HER2 negative disease, the rate of detection is pretty low, right? We see a rate of maybe we're estimating about 5 to 10%. So I think even with the different subtypes of breast cancer, the timing of ctDNA positivity, what this means in terms of the biology beyond just prognosis, there are lots of questions that still need to be answered.
Well, thank you so much.